About October or November, when the flu season really, kind of starts picking up, most of us would say, yes, we don't want a cold and we don't want our children to have a cold. But in my family, my perceptions of the severity, and in some cases the susceptibility, are heightened or increased dramatically, because if my children contract a cold in November, they will cough until January or February. They really will cough for several months, because the outcome may actually be worse, given that there is a this comorbid condition of asthma, and so my perception is increased, and that is another example of a modifying influence or a modifying variable. So think about, what are some of the most powerful modifying influences in our lives? Families, given that they share with us much information, but in some cases it's information not really communicated in a traditional didactic sense, but sometimes in just a demonstration of behaviors. So mothers that breastfeed oftentimes have daughters that breastfeed. Religion. Is it culture? Is it media? Or is it all of those? And there may be others as well. Okay, next is cues to action. Now, cues to action, we can think of them as the precipitating force that makes the person feel the need to take action. So you can kind of think of this as being the event that occurs, or the catalyst, you can think of it that way, that causes behavior to change. So assuming that perceptions of severity, susceptibility, modifying influences, perceptions of barriers and benefits, if all of those are otherwise conducive to engaging in the behavior, sometimes the person just needs a cue to engage in the behavior. So for example, in a tuberculosis peer counseling intervention that we conducted in Southern California, we identified that if we helped kids, adolescents who were taking medication for tuberculosis, it's a pill a day for 9 months and is oftentimes forgotten, especially after several weeks. And so they would go months without taking a pill, and so we found that they sometimes needed just a simple cue to action. So it might be a call from a friend, a note on the mirror, an alarm clock, or some simple method that could cue their behavior. Now, in one of the other studies that you've read this semester related to breast cancer, and it was a study of breastfeeding, and it was a study of breastfeeding blogs. And what we found is that on breastfeeding blogs, there are a lot of cues to action. So people who say, just in some cases, very forward and kind of overt attempts to persuade people and get them to behave in certain ways, saying, I really think you should breastfeed. Breastfeeding is a really important behavior. It's very good for you and for the baby. Those are cues to action. And I said that we would see this again, and of course here's self-efficacy again. And again, self-efficacy is the belief or the confidence in your ability to perform a behavior. So here are a lot of the recent applications of the health belief model that I've seen. So one of them is certainly with screening behaviors, and again, tuberculosis, breast cancer, all sorts of different preventative related behaviors where people need to perceive that the outcome is bad, that they are susceptible. Now, we're seeing this as an important part now in breast cancer, where women that have family history of breast cancer, their perceptions of their susceptibility are higher. Many other preventative behaviors, such as wearing seatbelts, smoking cessation, and other things. Health promotion behaviors, getting people to exercise by emphasizing the benefits, increasing their self-efficacy, and more importantly, providing behavioral cues. So real quickly, just want to go through some, kind of walk you through a simple example using the health belief model as it might apply to breast cancer screening. So perceived susceptibility: if we believe we are at risk for acquiring breast cancer, then it is likely that we will act to get a mammography. So the health educator attempts to build activities that help the participants personalize the possibility of breast cancer incidence. So we might do lectures, a discussion, role play, simulation, or look at genetic histories, and that's a very popular one right now in public health, and that is trying to ascertain or determine your risk for susceptibility based on your family history. If we and now perceive severity: if we perceive that breast cancer has the potential to produce serious negative consequences, such as death for us, then it is likely that we will act to reduce risk in our lives. So the health educator informs and helps the participants personalize the seriousness of negative outcomes due to not getting screened. So you may talk about how serious this would be for you. You could die. Now, most women that would be getting breast cancer, not necessarily most, but many have children, and so you might emphasize the impact that this will have on your children as a way to increase the severity, not just for you, but for others. Perceived benefits: if we believe that we will benefit from getting a mammography, then it is likely that we will perform these new behaviors. So the health educator helps the participants appreciate benefits of a mammography. So again, we talk about the benefits of early detection. Perceived barriers: if we can reassure ourselves that getting a mammography will have minimal expense on our part and maximal benefit in the long run, that is likely that we will perform these new behaviors. So the health educator helps the participants grasp the understanding of the barriers. And in some cases, we may actually try and do what we call barrier reduction, or addressing barriers intervention, where we may host or sponsor a free screening event. And you'll see this oftentimes for diabetes screening and other types of things, where the health department or some other group will sponsor a free screening. And that's quite simply just an attempt to reduce barriers. Cues to action: if we can identify our personal stimuli that trigger, again the catalyst, the mammography, then it is likely that we will perform the new behaviors leading to mammography. So the health educator helps the participants identify triggers. So what would it be? Would it be, in order to trigger this behavior, do you need a friend to call you? Do you, if it's other behaviors, not just mammographies, do you need an alarm clock, a diary? You may need, for getting a mammography, a family member or a spouse, a husband, to say, hey, I really would like you to go get screened. That would be a very strong cue to action. And lastly, if we can practice new behaviors related to getting a mammography in small steps and demonstrate that we have acquired mastery over these new behaviors, then it is likely that we will perform these new behaviors. So the health educator arranges for practice sessions. So many women may be very nervous or anxious about getting a mammography, not just because of the outcome, but also because of the uncomfortable situation that it may place them in, socially and physically. So it's not a very comfortable thing, and it's also can be socially embarrassing, as many women report. And so by working in a one-on-one setting, or a health educator could be working with a woman to help her in slow steps gain mastery, experience, and increase her self-efficacy such that she could feel comfortable getting a mammography. Now, in terms of limitations of the health belief model, the model lacks consistent predictive power, in part because it focuses on a limited number of these factors. So And you may recall our discussion about the theory of reasoned action also suffered from a limited number of factors, and so it was expanded to include the environment, perceived behavioral control, which changed the name to the theory of planned behavior. Well, the health belief model is very similar in that regard, in that it really is kind of a narrow scope of constructs that we're focusing on. Therefore, it may not account for behavior in all settings. Measurement error in operationalization. What I mean here is that it can be really difficult. Well, so sometimes perceptions of barriers and perceptions of benefits may be positive, and they may also be negative. So you could perceive barriers to be high, but you could also perceive no barriers. And so you could perceive benefits to be high, but you could also perceive no benefits, but almost is no benefits. So let's say you measured it on a scale of 1 to 3. And 3 is high, 1 and 2 is sort of high, 1 is not high, and 0 is 0. So it's really difficult to say that the distance between 1 and 2 is the same as 0 to 1, whereas that no benefits and perceiving absolutely no benefit to engaging in the behavior conceptually seems so much greater than the distance from 1 to 2. And so that it's simply kind of a measurement problem. So the other kind of important thing is that it's very context specific. So this last bullet point here, that we need to use behavioral anchors in articulating questions. So for example, we say, if you do not practice safer sex, how likely are you to become infected with HIV and AIDS? As opposed to how likely are you to become infected with HIV/AIDS. Now, it's kind of a semantics thing, but it is very important. And so if we just generally focus on, for example, how likely are you to become infected with HIV/AIDS, if we were to ask most BYU students that would not be sexually active, unless they're married, in which case they would perceive their risk to be very low. So you would say most students, if I were to say how likely are you to become infected with HIV/AIDS, perception of susceptibility would be very low. Nevertheless, if I asked you if you do not practice safer sex, this no longer precludes you from responding to this question, how likely are you to become infected with HIV/AIDS, you would probably report really high. And so it's just, again, it's kind of a semantics thing, but it makes a big difference in our measurement and interpretation of these constructs. And so we need to be really careful in that regard.